So if you walk into a clinic, right, and you have this noticeably swollen neck, you'd probably think the first thing the doctor's going to ask you is about your pain.
Oh, for sure. You'd expect them to ask, like, does it hurt when you press on it or something like that?
Exactly. But usually, the most important question they actually ask you is, did you notice this lump yourself in the mirror, or did a friend point it out to you?
Which is such a wild question. I mean, it sounds like small talk or maybe just a weird question about your social life.
Yeah, like who are you hanging out with?
Right, but in reality, the doctor is, they're deploying this highly calculated diagnostic trap.
And today, we are going to look at the exact blueprint for those traps. We've got our hands on this really fascinating set of source materials for today's deep dive. They are handwritten clinical study notes.
Yeah, these are amazing. They're essentially a diagnostic cheat sheet for medical students and doctors.
Right, teaching them exactly how to take a really comprehensive patient history, specifically for the head, neck, and the ear, nose, and throat issues, ENT stuff.
Just looking at these pages, with all the scribbled margins and these highlighted acronyms everywhere, it's like getting the cipher to a secret language.
It really is.
It reveals the whole underlying logic of medical investigation.
So our mission for this deep dive is to basically decode that language. We're going to explore how doctors use these incredibly rigid mnemonics to translate your vague aches or pains and dizzy spells into a super targeted, precise medical diagnosis.
Yeah, because by the end of this, you will completely understand the hidden machinery behind those seemingly random questions you always get asked on the exam table.
Right, it's not just idle chatter.
No, not at all. It's really a masterclass in how to systematically eliminate variables when you're dealing with the human body.
Okay, so let's unpack this. I want to start with that swollen neck scenario on the very first page of the notes here.
The thyroid history section.
Yes, exactly. So when a patient presents with a lump, the doctor doesn't just, guess what it is based on how it looks. They trigger this mnemonic. And the one written in big bold letters here is DOPSI-P-T-S.
Right, DOPSI-P-A-T-S.
Yeah, which just looks like a chaotic string of letters to me.
It does, but it actually forces the doctor into this really rigid analytical framework. So it stands for duration, onset, progression, site or size, intermittent, pain, aggravates, treatment, and skin changes.
Wow, okay. And the granularity they are expected to extract from those letters is what really caught my attention. Like under the size category, the student is specifically instructed to ask, is it pea size or lemon size?
They need a real-world visual.
Yeah, and then under aggravates, they have to find out if the swelling bulges outward when the patient coughs or strains or even just swallows a meal.
Which is so crucial because how a lump behaves under physiological stress, it tells the doctor exactly what anatomical structures it's tethered to.
Oh, interesting. So the movement gives it away.
Exactly. Like if a mass moves up and down when you swallow, it is almost certainly attached to the thyroid gland.
Because the thyroid moves.
Right, because the thyroid gland is physically wrapped around your trachea, and your trachea naturally moves up and down during the swallowing reflex.
Okay, that makes sense.
Yeah, so if the lump was attached to, say, a lymph node instead, it would move the same way when you swallow.
Wow. Which actually brings us back to that strange question I mentioned at the start, under the onset category. The notes specifically instruct the doctor to ask who noticed the lump first.
The mirror versus the friend question.
Right, and I actually spent some time thinking about this, and my theory is that it's essentially a test of visual familiarity.
Oh, like that. How do you mean?
Well, you look at your own face in the mirror every single day, right?
Sure.
So you are basically entirely blind to a change that only adds like a millimeter of growth a week. It's too gradual.
That is the exact psychology at play there. Asking who noticed it acts as a temporal yardstick.
A temporal yardstick, right?
Yeah, so if a patient says, I woke up, looked in the mirror, and a golf ball was just sticking out of my neck, the doctor immediately knows this is an acute sudden onset.
Because it happened overnight.
Exactly, so they instantly start thinking about, maybe a ruptured cyst or some kind of fast-moving infection.
But if the patient says, well, I met an old friend for coffee who I haven't seen in a year, and they immediately ask what was wrong with my throat.
Then the doctor knows this is a chronic, slow-growing mass.
Because the friend has a different baseline.
Right, a friend spots a slow-growing goiter instantly because they have a baseline memory of your face from 12 months ago.
That is just brilliant.
The doctor is literally using the patient's social interactions to build a timeline of cellular growth.
That is such a clever way to just bypass human memory flaws. And beyond the physical lump, the notes then dive deep into the systemic symptoms to figure out if the thyroid is overactive, so hyperthyroidism, or underactive, which is hypothyroidism.
Yeah, there's a whole checklist for that.
Right, the doctor has to sweep for these 9 contrasting symptoms. It's fascinating, like heat versus cold intolerance, crippling anxiety versus complete lethargy, unexplained weight loss versus sudden weight gain, even diarrhea versus constipation.
Well, the thing to remember is the thyroid is essentially the body's internal thermostat. It's the master engine regulator.
Okay.
So when we talk about hyperthyroidism, the engine is basically redlining.
It's going way too fast.
Exactly. The metabolism is burning energy so fast that the body generates excess heat, which is where the heat intolerance comes from.
Oh, so you're literally overheating.
Yeah. And the nervous system gets overstimulated, which causes the anxiety and a racing heart. Even the digestive tract moves too quickly, and that leads to the diarrhea.
And so hypothyroidism is just the exact inverse of all that.
Precisely, the engine barely turns over.
So you freeze in a warm room, your gut slows to a halt, causing constipation, and you gain weight because your body just isn't burning any fuel.
You got it.
But okay, here's where I really have to push back on something I found written in these notes.
Oh, what's that?
So in the risks section, right alongside stuff like radiation exposure and family history, I see goitrogenic food listed. And the examples they give are tomatoes, cabbage, cauliflower, radish, and spinach.
Yes, the vegetables.
Wait a minute though, how on earth are spinach and cabbage a medical risk? I mean, we are told by literally every health professional ever to eat a diet heavy in those exact vegetables.
It sounds contradictory, I know. But what's really fascinating here is the underlying biochemistry. It shows how a normally healthy habit can actually turn into a biological roadblock under very specific conditions.
A roadblock how?
Well, vegetables like raw cabbage and spinach contain these compounds called goitrogens. And these compounds can physically block the thyroid gland from absorbing iodine from your blood.
And iodine is like the raw material the thyroid uses to manufacture its hormones, right?
Exactly. It needs iodine to function. So if we connect this to the bigger picture, the mystery totally clears up when you look at the risk factor listed directly below those vegetables in the notes.
Let me look up. Oh, iodized salt.
Right. So let's say a patient is on this extreme raw juicing diet. Right. They're consuming massive amounts of raw spinach every day.
Okay, lots of goitrogens.
Yep. And if they also happen to live in an area with iodine-deficient soil, or they deliberately avoid iodized salt because of some diet trend, they're effectively starting their thyroid.
Oh wow, so the thyroid isn't getting what it needs, and the spinach is blocking whatever little bit is left.
Exactly.
So the thyroid just basically goes into overdrive. It swells up, like increasing its own surface area to try and catch whatever tiny microscopic traces of iodine are still floating by in the bloodstream.
And that biological desperation, that swelling, is exactly what creates a goiter. It becomes a massive swollen gland.
That is wild.
So the doctor, reviewing these notes, they're just taking a medical history. They're basically taking a culinary history to find this missing chemical link.
It really perfectly illustrates how our internal chemistry dictates physical changes, but from here, the notes completely shift focus. We actually move up from the neck and into the mouth.
The oral cavity section.
Right, and the diagnostic environment here changes completely. Like, we leave behind all those internal metabolic balances, and we just start looking at the literal mechanical wear and tear of everyday life.
Yeah, the oral cavity requires a totally different investigative mindset. The mnemonic actually modifies slightly here for a non-healing ulcer or a growth. It changes to DOPSI-PAD-SR.
They added an R.
Right, the addition of the R reminds the doctor to ask about prior radiation therapy, because that's a massive factor in oral tissue damage.
But what really stood out to me here was the aggravated by category. Like, for a mouth ulcer, the doctor is explicitly hunting for mechanical friction.
Physical damage, yeah.
They ask about trauma, corrosive ingestion, spicy food, and even accidental biting. The notes tell the doctor to actively hunt for jagged teeth or ill-fitting dentures. And to me, a jagged tooth is kind of like having a tiny pebble in in your shoe.
Oh, that analogy hits the nail right on the head regarding the mechanism of injury.
Yeah, because if you have a pebble in your shoe, taking just one step isn't a huge deal, right? It's just a minor annoyance.
Right, you barely notice it.
But if you are forced to run a 26-mile marathon with that same pebble, by the end of the race, the friction is going to have rubbed your foot into this bloody, ulcerated mess.
And your mouth is essentially running a marathon every single day.
Yeah, you chew, you swallow, you speak.
Right, so a cheap set of dentures that shifts around or a sharp fractured molar, it creates this constant, repetitive physical trauma against the really delicate mucosal lining of your cheek.
That's constant friction.
Exactly. And over months or even years, that chronic inflammation forces your cells to constantly repair themselves. And every time they repair, it massively increases the chance of a DNA copying error.
So that mechanical friction is literally paving the way for abnormal cell growth.
Yes, or even oral cancer.
Wow. The notes also spend a lot of time profiling the patient's specific behaviors. Under the hygiene section, they list things like bad breath, pus in the mouth, or numbness when brushing.
Those are key indicators.
And the doctor is also instructed to ask about chewing pan, tobacco, or gutka. But they don't just want a simple yes or no answer. They need the exact duration and frequency.
Because the dose makes the poison.
Right.
These betel nut mixtures like gutka, they are highly carcinogenic. So the doctor is building a statistical risk profile.
Like trying to see how much exposure they've actually had.
Exactly. I mean, chewing tobacco once a month versus keeping a pouch in your cheek for 6 hours a day, every single day for 20 years. That dictates two completely different investigative urgencies.
Yeah, that makes total sense. But the physical exam part of the oral cavity is where things get really deep to me. The function checks.
Ah, yes, the neurological side.
Yeah, so the doctor asks the patient to open their mouth wide, to move their tongue from side to side, and they monitor their articulation and their salivation. Now, as a patient, I'm sitting there thinking, okay, the doctor just wants to see if my jaw joint is stiff.
Right, check the mechanics.
But I have a suspicion reading this that there's way more going on. Like, wait, if I stick my tongue out, how does that test anything other than just my tongue muscle? Are those muscles wired directly into the brainstem or something?
They absolutely are. Those function checks are basically neurological tests hidden in plain sight.
Hidden in plain sight, wow.
Yeah, so the tongue is controlled by the hypoglossal nerve, right? Which is the 12th cranial nerve, and it originates deep, deep inside the brainstem.
Okay.
So if a doctor asks you to stick your tongue straight out and it involuntarily hooks or deviates to the left, that isn't a mouth problem.
It's not just a weak muscle.
No, that tells the doctor the left hypoglossal nerve is actually failing. It's possibly being compressed by a tumor somewhere along its pathway.
So by just like listening to someone's articulation or watching them try to swallow a sip of water, the doctor is basically running a remote diagnostic on the brain's internal wiring.
You've got it. The oral cavity is just the terminal end of this massive neural network. Altered salivation, facial numbness, a dragging tongue, every single one of those symptoms maps back to a specific cranial nerve.
That neurological mapping bridges us perfectly to the third page of the notes, because up until now, a doctor has been dealing with physical evidence, right?
Things they can actually see or feel.
Yeah, they can palpate a lump, they can look at a jagged tooth, they can literally watch a tongue deviate. But suddenly, the notes pivot to a symptom that is entirely invisible and completely subjective, which is vertigo.
Oh, vertigo. It's a total diagnostic nightmare for a young doctor.
Really? Why is that?
Because you're relying on a patient who is currently disoriented, nauseous, and probably terrified to accurately describe a completely invisible sensation.
That does sound tough. So the students rely on another mnemonic here, DYTCT2, duration, onset, intermittent, timing, characteristic, aggravation, association, and treatment. But the true gold mine on this page is actually scribbled in the top margin.
The temporal breakdown.
Yes, it is a diagnostic cheat sheet that literally filters out diseases based on a single metric, time.
It is an incredibly elegant way to eliminate variables.
So the notes break it down like this. If the vertigo lasts just a few seconds, the doctor should suspect trigeminal neuralgia.
Right.
Then, if the spinning lasts from seconds to minutes, it points to BP fluvi or paralimb fistula.
Exactly.
And if you are dizzy for minutes to hours, you are looking at a TIA, which is a mini stroke.
Yeah.
And finally, if the vertigo lasts for many hours or even days, it's Meniere's disease or some kind of acoustic issue. But my question is, how does simply looking at a watch rule out so many complex diseases?
Well, it works because the underlying biology of these diseases operate on really strict physical timelines.
Okay, break that down for me.
Let's look at trigeminal neuralgia first, which lasts seconds. That is a nerve condition where a blood vessel is literally pressing against the trigeminal nerve inside your head.
Ouch.
Yeah. And the resulting symptom is basically like a lightning strike. It's a sudden, severe misfire of electrical pain or disorientation that vanishes almost instantly.
Ah, I see. A nerve spark simply doesn't last for hours.
Exactly.
Okay, so what about BPPV then, which lasts seconds to minutes? What does that even stand for?
So BPPV stands for benign paroxysmal positional vertigo.
That is quite the mouthful.
It is. But basically inside your inner ear, you have these tiny calcium crystals that help your body sense gravity.
Crystals, like actual rocks in your head.
Yeah, basically. And sometimes they break loose and they float into the fluid-filled semicircular canals where they really don't belong.
Oh, that sounds bad.
So when you tilt your head, those heavy crystals slosh the fluid around, and it sends a false signal to your brain that you are actively spinning.
But the vertigo only lasts, what, a few minutes?
Right, it only lasts as long as it takes for those physical crystals to settle back at the bottom of the canal. Gravity takes over in a matter of seconds or minutes.
Okay, that makes total sense mechanically, but a TIA, a transient ischemic attack, which lasts minutes to hours, that's a completely different mechanism, right? That's a temporary blockage of blood flow to the brain.
Yes, exactly. So in that case, the brain software is glitching because it's actively being starved of oxygen.
And I'm guessing that takes longer to fix?
Way longer. It takes much longer for neurological tissue to reboot and recover from oxygen deprivation than it takes for those little ear crystals to just settle out in fluid.
And finally, Meniere's disease, which the notes say lasts for hours or days.
Right, that involves a chronic buildup of fluid pressure deep inside the inner ear compartment. And that kind of pressure takes a very, very long time to equalize.
So literally just by pinning down the exact duration of the dizziness, the doctor isolates the anatomical mechanism causing it.
It's all about time.
Here's where it gets really interesting to me though. Under the characteristics section, the notes demand the doctor ask a highly specific question. They have to ask, do you rotate or does the environment rotate?
Subjective versus objective.
Yeah, but put yourself in the patient's shoes for a second. You feel like you are falling off the earth, you are super nauseous, and the doctor calmly asks, excuse me, but are you spinning or is the wall spinning? Like how can a patient possibly parse that distinction in that moment?
I know, it's a really difficult question to answer. But think of it like sitting on a stationary train.
Okay.
You are looking out the window, right? And the train on the tracks next to you starts rolling forward. For a split second, your brain completely panics.
Oh yeah, I hate that feeling.
Where your eyes see movement, but your inner ear feels no physical acceleration. So you suddenly feel like you are moving backward. That weird sensory mismatch is exactly what the doctor's trying to decode.
So if you feel like you are spinning inside a stationary room, which is what they call subjective vertigo, versus the whole room violently spinning around you, which is objective vertigo.
Yeah, exactly.
That tells the doctor if the glitch is in the ear's hardware or the brain's software.
Exactly the case. Objective vertigo usually points to an issue in the ear, while subjective points deeper into the central nervous system.
And the aggravation section supports that too. Doctors look for really strange triggers, like vertigo that starts when you just touch the ear, or if you hear loud sounds, or even just looking upward.
They're looking for mechanical triggers.
Right. But the complications list is what really raises the stakes here. The notes warn the doctor to actively look for facial weakness, double vision, photophobia, which is that severe sensitivity to light and neck stiffness.
Because that list of complications proves that localized symptoms in the head and neck are rarely just isolated events.
They're connected.
Very connected. If a patient has vertigo, but their left eye can't look outward and their face is drooping, the inner ear is no longer the prime suspect. The brainstem itself is failing.
But the brainstem isn't the only system that can hijack the head and neck. When a localized symptom is actually a distress signal for the whole body, doctors have to sweep for systemic red flags. Which leads us to the final section of these notes, labeled associations.
This is where the medical student learns to kind of pull back from the microscope and look at the entire organism as a whole.
Yeah, they have a whole checklist of systemic failures to ask about, regardless of why the patient actually booked the appointment, like fever, night sweats, weight loss, and bone pain.
Because if a patient comes in for, say, just a swollen lymph node in their neck, and then casually mentions they've been drenching their bed sheets in sweat every night and dropping weight without even trying, the entire diagnostic trajectory changes.
Because those are no longer just neck symptoms?
No, they are the classic B symptoms of lymphoma, which is a systemic blood cancer. The immune system is essentially at war. It's releasing cytokines that cause the body's temperature to spike at night, and the cancer is consuming so much metabolic energy that the patient rapidly loses weight. The doctor has to actively hunt for those systemic clues.
And to ensure they never miss these clues, the students use this medical shorthand that sounds kind of like coordinates on a map. It's the D2 and H4 rule.
That's a vital one.
Let's break down those terms first. So D2 stands for two D words: dysphagia, meaning difficulty swallowing, and dyspnea, which is shortness of breath.
Right.
And then H4 covers four pretty terrifying H symptoms: hematemesis, meaning vomiting blood; hemoptysis, meaning coughing up blood; hoarseness, and headache.
If any of those D2 or H4 symptoms are present alongside an ear, nose, or throat complaint, the diagnostic urgency skyrockets.
Let's explore why, though. Because at first glance, like vomiting blood seems like a stomach issue, not an ear or throat issue. Why does an ENT doctor care about hematemesis?
Well, because the throat is basically a shared highway. The air digestive tract connects the mouth to both the lungs and the stomach.
It's all connected.
Exactly. So if a patient has an aggressive ulcer in their mouth or throat, and they are vomiting or coughing up blood,
Yeah.
it indicates the pathology is deeply invasive.
Like it's spreading.
Yeah, it might be eroding into major blood vessels, or a tumor has spread down into the gastrointestinal or respiratory systems.
Oh man. And what about hoarseness? Like if I go in for a lump in my neck, why does a raspy voice matter at all?
That brings us right back to the nerve mapping we talked about earlier. Your vocal cords are controlled by the recurrent laryngeal nerve. And interestingly, this nerve pathway dips way down into your neck and your upper chest before it actually wraps back up to your voice box.
Wait, it goes all the way down just to come back up?
It does. It's an evolutionary quirk.
Yeah.
But it means that if a tumor is growing deep in your neck or your upper lung, it can physically crush that nerve pathway, which paralyzes one of your vocal cords.
Wow.
So the hoarseness is essentially an audible alarm that something deep in the chest cavity is expanding.
Okay, I follow the logic there. But right at the bottom of this really intense list of red flags, there is a question that completely threw me. The doctor is instructed to ask about nasal regurgitation, which just means fluid coming out of your nose when you swallow.
Right.
And then immediately after that, they must ask, right or left-handed?
Yep.
I have to push back here. If I'm dizzy or I'm literally coughing up blood, why does a doctor care which hand I use to write my grocery list? That seems totally irrelevant.
It sounds absurd, I know, but if we connect this to the bigger picture of neurology, it is actually one of the most elegant questions on the entire page.
Really? How so?
Let's go back to the vertigo complications. Say a patient is dizzy, they have facial weakness, and they are actively struggling to speak. The doctor suspects a stroke or a TIA.
Right, so a brain issue.
Exactly. Now, the human brain is asymmetrical regarding certain high-level functions, most notably language. For the vast majority of right-handed people, their language centers, specifically Broca's and Wernicke's areas, are located solidly in the left hemisphere of their brain.
Oh wow, I see where this is going.
Right, but for left-handed people, that language dominance can actually be located on the right side of the brain, or it can even be distributed bilaterally across both hemispheres.
That is wild.
So if a doctor suspects you are having a stroke because your speech is slurring, just knowing your dominant hand instantly helps them map exactly which hemisphere of your brain is suffering from a lack of blood flow.
That is incredible. They ask if you are a lefty or a righty, just so they know which side of your skull to focus the MRI on.
Exactly. It is a crucial piece of neurological data, cleverly disguised as small talk.
The entire physical exam is essentially just an exercise in gathering hidden data.
It really is.
So what does this all mean for you, listening to this right now? I think the biggest takeaway is really just a shift in perspective.
A newfound respect for the process.
Yeah. The next time you sit on that crinkly paper on an exam table, and the doctor asks if your dizzy spell lasted for 30 seconds or 3 hours, or if they casually ask whether you noticed your neck lump in the rearview mirror, or if your spouse pointed it out to you.
You will know they aren't just making small talk to fill the silence.
Exactly. They are actively navigating a highly sophisticated, completely invisible matrix of data. They are running physiological algorithms right in their head, relying on these secret codes like DOPS IPAT-S and DYT-T2 to systematically eliminate possibilities and isolate exactly what is misfiring inside your body.
It's all highly calculated.
And this actually raises a really provocative thought for everyone to mull over long after we sign off today. We tend to think of these doctors as, infallible geniuses with perfect recall, but these notes reveal a pretty humbling admission about the human brain.
Yeah, that's the real secret here. The smartest surgeons and diagnosticians in the entire world. They know that human memory is completely unreliable under pressure. In a high-stakes, life-or-death environment, they do not trust their own brains to remember 9 simple letters without a mnemonic cheat sheet. They rely on these rigid frameworks to eliminate cognitive bias and prevent catastrophic forgetfulness.
So the question to really ask yourself is, if the experts don't trust their unassisted memory when the stakes are high, why do the rest of us rely purely on memory during critical moments in our own careers? Sometimes flawlessly solving a complex problem isn't about natural brilliance. It's just about having the discipline to run the checklist. Making sure you ask if the pebble is in the left shoe or the right. We'll catch you on the next deep dive.